السلام عليكم طلابنا الأعزاء. محاضرتنا اليوم بعنوان The Pre-Labor Rupture of the Membrane، وهي مكملة لمحاضرة ال Pre-Term Labor. محاضرة أيضا مهمة جدا، أرجو الانتباه عليها. Pre-Labor Rupture of the Membrane, defined as rupture of the membrane with leakage of the amniotic fluid in the absence of the uterine activity or before the onset of the labor. When the gestational age is less than 37 weeks, we call it preterm pre-labor rupture of the membrane. The incidence of this condition occur in about 8% إذا كان term، ويصير 2 إلى 3% إذا كانت preterm. الكوزز هي نفسها تقريبا الكوزز of preterm labor: uterine oval distension, decidual reactions, vascular disorders, infections, stress, decline in the progesterone action, cervical disease. okay, واحيانا unknown causes. How can you diagnose such condition? Clinical diagnosis and assessment. First of all, history. History. Symptoms are the key to the diagnosis. The patient usually report a sudden rush of a fluid, which is a watery vaginal discharge or continued leakage. يعني راح تقول لك دكتور أنا حسيت فجأة أكو مي كلش قوي إجا علي، أو أحيانا لا والله أنا مستمر هذا السائل. أوكي، بعد نسألها على السائل أيضا أكيد لازم الكلر، amount، الأودر. أوكي، هاي الكرايتيريا الأخرى بالهيستوري. any associated abdominal pain, any associated other disease infections, symptoms of infections, discharge, itching, fever, whatever. Well, after taking the history from the patient, we should do examination, and the work of examination involves sterile speculum examination, which is very necessary to confirm the diagnosis for direct visualization of the leakage. ومن نقول sterile speculum examination، patient قاعد تجيك هي preterm، يعني بعدها ما صار 37 week، يفضل احنا ما نسوي any vaginal examination إلا إذا it was indicated. بهالحالة it is indicated. وستيرايل يعني السبيكولم لازم يكون ستيرايد. الجلوبس لازم نستخدم السيرجيكال جلوبس اللي هي الستيرايد ايضا، وهاي الجلوبس العادية الموجودة. اوكي، ونسوي لها الاكزامينيشن. طبعا البيشنت حتكون بالليثوتومي بوزيشن، تبقى حوالي 15 minute الى 20 minute. راح نشوف اكو فد pooling of the amniotic fluid وين موجود بالبوستيريور بليد of the casco speculum. راح نستخدم هنا speculum اللي هو الكاسكا speculum. غير الدايركت visualization of the fluid of the amniotic fluid، الفرنج والنيترازين تيست، وهسه راح نشرحها بالتفصيل. Preterm premature rupture of membrane should be confirmed by sterile speculum examination performed after the mother has rested in supine for 20 to 30 minutes. Amniotic fluid should be seen pooling in the posterior fornix. The examiner should look for the three hallmark confirmatory findings associated with premature rupture of membrane. These are the pooling مثل ما قلنا، النيترازين تيست والفرنج تيست. النيترازين تيست هذا التيست نسويه حيغير اللون البيبر من مثلا يلو الى يعني تقريبا جرين تو بلاك ان كذا، فاذا تغيرت الى بلاك هذا indicate a positive amniotic fluid. والفرنج fluid from the posterior fornix is placed on a slide and allowed to dry in the air. Amniotic fluid will form a fern-like pattern of crystallization. ونقصد بالفرن مثل السقفة، بس راح أشوفكم هذه الصورة اللي توضح هذا الكلام. تبوا هذا هنا هو الفرنج كلش واضح crystallizations. اوكي، هذا معناها هذا amniotic fluid. وهذا النيترازين تيست، شوفوا إذا عندنا ربشر ممبرين حيكون لونه يا اما جرين يا اما يعني بلو بس غامق او بلاك. اوكي، واذا عندك ممبرين حيكون هذا اللون يلو، يبقى ضمن هذا اللون الصفارات. اوكي. examination اللي هو BV examination should be avoided unless the patient is thought to be in established labor as it is known to be increase the incidence of. why؟ يعني هسه أنا البي في examination ما أسوي إلا إذا البيشنت كان عندها uterine contractions قاعد تشكي من abdominal pain، ذاك الوقت أني should assess the cervical dilatation مو حتى نعرف هي عندها preterm labor لو لا. أوكي. فإذا عندها ليبر إذا أشوف الدايليتيشن إيش قد حتى أكمل الليبر أخليها تستمر لو أقدر أوقفها مثل ما قلنا بالمحاضرة السابقة. زين أنا ليش ما أسوي الديجيتال examination؟ why؟ because the risk of chorioamnitis, postpartum endometritis and neonatal infections all these will increase by BV examination خاصة a repeated BV examination. What else we should do? Ultrasound. We should evaluate the amniotic fluid volume, usually measured by the deepest vertical pocket or amniotic fluid index, which is maybe useful for additional investigation in those women with a strong history of premature rupture of membrane. In addition, ultrasound is useful to assess the fetal presentation, biometry of the gestational age, anatomy, the placenta location والcord position. cervical culture قلنا احنا infections واحدة من causes of preterm rupture of membrane. So cervical culture including chlamydia trachomatis, Neisseria gonorrhea is indicated especially in high risk group. When group B streptococcal infection should be cultured and should be sent from anorectal and vaginal area. There are specialized tests that can be used for a premature rupture of membrane. These are done by vaginal swab for fibronectin, fetal fibronectin. الفيتال fibronectin is a glycoprotein. It is a glycoprotein. هذا الفibronectin. It is present in a large amount in the amniotic fluid. It can be detected in the endocervix or in the vagina of the patient with a premature rupture of membrane by ELISA test. Insulin growth factor أيضا موجودة والبيتا اس جي يكون موجود بهذا الامنيوتيك fluid. All these above three tests are present in high concentration in the amniotic fluid and have available rapid bedside test. فيعني أقدر أفحصها وأقدر أتأكد إنه هذا فعلا لايكر مو يورين ولا any vaginal discharge. What else? Amniocentesis. Amniocentesis can be of use for the evaluation of what? أولا, the diagnosis. If the diagnosis is doubt, 1 millim of indigo carmine in 9 ml of normal saline can be injected into the amniotic cavity under a continuous ultrasound guidance present the presence of blue on a pad or in the perineum. شنو هذا؟ أنا شو راح أسوي هسه؟ أنا دخلت السرنج بالامنيوتيك كافيتي ودفعت صبغة، أوكي؟ طبعا under ultrasound guidance مستمر. إذا فعلا عندي rupture of membrane راح نشوف بالباد اللي حطتها المريضة جواها راح نشوف تغير اللون وصار بلو. إذا هذا فعلا amniotic fluid rupture. هاي الطريقة مو كلش يعني indicated يعني carry a risk. بعد أقدر أسوي examine of amniocentesis can be of يعني beneficial in the infectious state of the amniotic cavity. send amniotic fluid glucose إذا كان عندنا أقل من 15 ملغ per deciliter associated with positive culture. جرام ستين أقدر أسوي and also culture for sensitivity. fetal وهذه أهم نقطة اللي هي الفيتال lung maturity. The result of a similar accuracy to amniocentesis can be obtained non-invasively by collecting vaginal fluid using a bed pan. فإذا أنا الامنيوسنتيسيس يعني مو كلش هواية حنحددها. why؟ لأنه it carry risk of infection. البيشنت اوريدي هي عندها rupture membrane وليكينج لايكر، فأنا ما أقدر أخاطر وأجازف وأجي أسحب وأقلل بالزايد، أوكي؟ فيعني نقدر نستخدم الامنيوتيك فلويد اللي موجود عندنا دا ينزل من السيرفكس، أقدر أستخدمه for assessment of fetal lung maturity but it has been theoretically present and you should understand it. Now ويعني صار عندنا rupture of membrane Is there any complication for this condition? Yes, there is. واحدة من هذول infection وقلنا chorioamnitis وعرفنا signs and symptoms of chorioamnitis in the previous lecture. وبعد عندنا premature labor and delivery with related complication of prematurity واللي هي حيصير عندنا respiratory distress syndrome, intraventricular hemorrhage, periventricular decomalacia, infection والnecrotizing enterocolitis. احتمال يصير عندنا rupture placenta اللي هو premature separation of normally sensitive placenta. Fetal distress variable deceleration may occur due to the cord compression لأن ما عندنا fluid كافي amniotic fluid كافي. There are certain complications, especially for those who are less than 24 weeks, and these include prenatal death, perinatal death. Pulmonary hypoplasia is frequent when premature rupture of membrane occurs before 26 weeks, and the latent period prolonged for more than 5 weeks. Compression deformities, facial and skeletal deformities may occur with prolonged rupture of membrane. Long-term infant morbidity, an increasing need for cesarean delivery, and retained placenta has been reported. Now, what are the management of patient with a premature rupture of membrane? طبعا the management continue to be controversial. However, many obstetricians will institute conservative management in the preterm premature rupture of membrane before 34 weeks and would induce labor relatively early in women whose membrane rupture occurs subsequently to 37 weeks of gestation. There is currently no good evidence as to what ideal management should be between 34 and 37. يعني بين قوسين أي مريضة تجي قبل 34 أسبوع وما عندها ليبر نقدر نسوي لها conservative management. أي مريضة جتي بعد 37 week أقدر induce her labor and deliver her. لكن وقت ideal management اللي يجي ما بين 34 week و 37 week لحد الآن there are no baseline. أول نقطة وأهم نقطة for the management هو you should be very accurate in the determination of gestational age. First نجي إذا كانت البيشنت مالتك term premature rupture of membrane pre-labor rupture of membrane, the interval between the preterm rupture of membrane and the onset of spontaneous labor اللي هي latent period and delivery varies inversely with the gestational age. يعني at term أكثر من 90% of women with a premature rupture of membrane will begin labor within 24 hours. لكن at 32 to 34 week المين latency period حتكون 4 days. يعني كل ما يزداد الأيج كل ما تقل الفترة ما بين الرابتشر membrane والinduction of labor أو يعني إنه labor تبدي spontaneously. التيرم تشوفون شلون إنه التيرم صارت أكثر من 90% من البيشنت حيصير عندهم ليبر خلال 24 ساعة، لكن لما يكون الجستيشنال ايج ما بين 32 ويك and 34 ويك لا حنشوف تقريبا حتصير 4 days. إذا the term of pregnancy اللي هو يعني expected gestational age equal or greater than 37 week with pre-labor rupture of membrane in the absence of infection can be managed expectantly or actively. Expected management entails non-intervention while waiting for the patient to go into a spontaneous labor. يعني أعوفها براحتها وهي تصير labor خلال 24 ساعة احتمال. لكن الأكتيف مانجمنت لا أني أسوي induction of labor by any يعني agent like for example oxytocin, pitocin, okay? Non-intervention is an acceptable initial course of treatment, but if the patient doesn't go into labor within 6 to 12 hours after rupture of membrane, labor should be induced. Why? To minimize the risk of infection. يعني مريضتك لما تعبر 24 ساعة وهي rupture membrane وكل شيء مسوي لها وما صار عندها labor, don't let her to go. لا. Start induction of labor because the risk of infection will be increased. عادة احنا ننتظر 6 إلى 12 ساعة إذا ما صار عندنا any labor, spontaneous labor, or we induce her labor. خلصنا البارت اللي يخص انه اذا كانت البيشنت تام، فالتام سهله تنحل بسهوله، ما عندنا اي مشكله. مشكلتنا ومقابلتنا هم البريتام. Now you should identify the patient who require delivery اللي هم الفيرست جروب. اولا which patient should be delivered. هاي البيشنت اجتك وعندها rupture of membrane leaking liquor. من يلي أنا أسوي لها لازم ديليفري؟ أولا patient in labor she had frequent uterine contraction cervix 100% يعني 100% effaced and 4 centimeter dilated or more. ثانيا mature fetal lung check by amniocentesis أو عن طريق الامنيوتيك fluid examination by sphingomyelin ratio أو phosphatidylglycerol. Fetal malformation gross anomaly incompatible with the life. Why you let her? مو ليش تعرفوها؟ هو راح تجيبه راح he will die. Okay, so let her labor start. Fetal distress, he will not be safe in the womb of the mother. Patient with overt infection. Patient with a clinical chorioamnitis should receive antibiotic before delivery in the form of what? Ampicillin 2 gram intravenously 4 times daily, metronidazole 500 milligram 3 times daily. Patient with subclinical amnionitis chorioamnitis يعني amniocentesis سويته وطلع لي الكلتشر بوزيتيف. patient at high risk for infection. من هم؟ هذول يكونون انه patient taking immunosuppression drugs, patient اللي هم عندهم history of rheumatic heart disease, اللي عندهم type 1 diabetes, اللي sickle cell disease, heart valve and those who have several pelvic examination since rupture of membrane occur. هاي رجاء يعني لا تنسوها. اوكي. Now خلصنا الجروب هذا الفيرست جروب انه you should what deliver her. طبعا اكو عندنا مانجمنت، اكو expected management، اكو conservative management. Expected management include in many unit women who are diagnosed to have a pre-labor rupture of membrane are admitted to the hospital and managed conservatively until 37 weeks of gestation in an attempt to increase the fetal lung maturity. A conservative management will include admission to the hospital, okay, and then limit the patient activity, advise her for bed rest, complete pelvic rest, and with a bathroom privilege. Maternal surveillance. All women with a premature rupture of membrane preterm should be monitored for signs and symptoms of infection by 4-hour measurement of maternal blood pressure, heart rate, respiratory rate, and blood pressure. يعني أنا أقيس لها الفيتال ساينز كل 4 ساعات. weekly نسوي maternal white cell count, C-reactive protein assay, and lower genital tract swab culture are routinely taken, all in an effort to detect intrauterine infection or chorioamnitis. والفيتال surveillance اللي هو شنو؟ The two most common types of fetal surveillance هو non-stress test and the biophysical profile. Any abnormalities of these tests can be somewhat predictive of fetal infection and umbilical cord compression related to oligohydramnion. Serial ultrasound for liquor volume for presentation weekly and growth every fortnight are arranged. Antibiotic قلنا إنه the regime studied by the National Institute of Child Health and the Human Developmental Trial uses an intravenous combination of 2 grams of ampicillin and 250 milligrams of erythromycin every 6 hours for 48 hours, followed by 250 milligrams of amoxicillin and 333 of erythromycin every 8 hours for 5 days. Women given this combination were more likely to stay pregnant for 3 weeks, despite discontinuation of the antibiotic after 7 days. Comoxiclav is not recommended for the woman with preterm rupture of membrane because there is increased risk of necrotizing enterocolitis. Now, طبعا يمشي مثل البريتام labor الcorticosteroid should be administered when the rupture of membrane occur ما بين 24 إلى 34 week of gestation as this intervention is associated with a lower incidence of respiratory RDS يعني وكذلك intraventricular hemorrhage necrotizing enterocolitis and a trend for lower neonatal death rate. They don't appear to increase the risk of infection in either the mother or baby. يعني ما أخاف أقول لا ما أنطيها الكورتيكوستيرويد أخاف يزيد الانفكشن لا بالعكس أنت will benefit the neonate. Tocolysis, is there any rule? May be used for a woman with a preterm premature rupture of membrane and have uterine activity who require intrauterine transfer or antenatal corticosteroid. يعني antitocolytic is given for less than 48 hours to allow administration of corticosteroid. إذا الرول of tocolytic هنا مو أمنع الليبر، هنا حتى شوي أهدئها لمدة يومين حتى allow the corticosteroid to work and also allow the patient to be transferred to an antenatal care or hospital equipped with a neonatal care unit. Amino-infusion for prolongation latency transabdominal amino-infusion is not recommended as a method for preventing of pulmonary hypoplasia in very preterm premature rupture of membrane. Fibrin glue. Fibrin glue and fibrin chelate are not recommended as a routine treatment for second trimester oligohydramnion caused by premature rupture of membrane. فيتامين سي اند اي شافوا انه اذا اعطينا المريضه فيتامين سي 500 ملغ وفيتامين اي 400 international unit may be helpful انه تاخر الليبر by about 7 days. اوكي لحد الان هذا theory و not approved. Is there any rule for outpatient management؟ هاي كلها الرول اللي حكيناها هسه قبل هو inpatient management مو؟ In rare selected cases, patients who remain undelivered may be candidate for outpatient monitoring. Monitoring should be considered only after a period of 48 to 72 hours of inpatient observation. If the leakage of the fluid stops, the amniotic fluid volume normalize, and the patient remain afebrile without evidence of increasing uterine irritability, she can be discharged home. إذا كان ما عندها discharge ما عندها any sign symptoms مال infection الامنيوتيك fluid volume رجع normal أقدر أني أخليها شنو ترجع للبيت. These patients should be monitored very closely on an outpatient basis. They must be reliable and compliant with a follow-up appointment. يعني أنصحها إنه تراجع بين فترة وأخرى ما تهمل نفسها. They also must take their temperature twice daily and be counseled on warning signs of chorioamnitis. أعلمها على signs of chorioamnitis اللي هي البين والtenderness والtachycardia. These patients should also be monitored with a frequent biophysical profile. Some sources recommended daily testing أحيانا. يعني تتوقعون هيك حالة راح تنجح يعني مو كلش نادرا لأنه it will need a continuous monitoring by the patient. لازم تكون highly educated و counseled about the risk. Now, what is the appropriate time to deliver? Delivery should be considered at 34 weeks of gestation. Pregnancies beyond 34 weeks can be managed as a teen pregnancy because there is no evidence that antibiotic, corticosteroid, or tocolytic improve the outcome in these patients. These patients can be managed expectantly as long as they show no signs of chorioamnitis. Randomized trials have suggested that policy of induction as opposite to the expected management may lead to the less hospitalization, less perinatal infection, and less neonatal morbidity. Even the induction is better than let the patient for a conservative management. While expected management is considered beyond 34 weeks of gestation, women should be counseled about what? About the increased risk of chorioamnitis and its sequelae. Now, آخر شيء بموضوعنا اللي هو إذا كان عندنا البري viable premature rupture of membrane إذا كان ما بين 23 إلى 24 week of gestation. مثل ما قلنا بالمحاضرة السابقة 24 hour of gestation و less هذا gestation of miscarriage. إذا صار عندنا rupture of membrane at this gestational age, there are significant risk of lethal pulmonary hypoplasia, a condition that cannot be reliably predicted on the prenatal ultrasound. Additional risk will include chronic pulmonary morbidity, fetal limb contractures. Many parents will opt for termination of pregnancy. ففي الحالة أنت you will let the patient to يعني حيصير هو termination spontaneously without any induction. Thank you for your listening to my lecture, and I hope you get the benefit from my explanation. I am ready for to answer you for any question. Thank you very much.